Welcome to Medhustle's class on vasculitis. So we will deal about vasculitis in two classes. So in this orientation, we'll deal with the classification of vasculitis proper. We'll discuss how to identify each type of vasculitis. We'll discuss in detail about the clinical features, the investigations and management, mainly the large vessel vasculitis in this class. So to define vasculitis, what is vasculitis? It is nothing but inflammation of the blood vessels in simple terms. The large, medium-sized, and the small-sized blood vessels. And the organ manifestations which occur are due to this inflammation. So now how do we approach questions on vasculitis? So the clinical vignette approach or the clinical features approach which is used is there are some typical keywords for each vasculitis which comprise the clinical features of that vasculitis. Then we deal with some of the inflammatory markers, the typical organs to see in each type of vasculitis which are affected, the investigations of choice, the management, and finally an integrated approach, putting all of this in total. So coming to the classification of vasculitis first. So this classification is known as the Chapel-Hill classification. Okay, so as you can see in the diagram, this classification has classified vasculitis into large vessel, medium vessel, and small vessel vasculitis. So the large vessel vasculitis typically is the TAKAYASU arthritis and the giant cell arthritis. The medium vessel vasculitis is polyarthritis nodosa or PAN in simple terms, and Kawasaki's disease. And coming to small vessel vasculitis, these are the vaginal granulomatosis, which is the old name. The current name is GPA, that is granulomatosis with polyangiitis. Church-Strauss syndrome, the new name of which is EGPA. Microscopic polyangiitis, HSP, that is Henoch-Schönlein purpura, essential cryoglobulic vasculitis, and cutaneous leukocytoclastic angiitis. So this is about the classification of vasculitis, which goes by the name Chapel-Hill classification of vasculitis. So granulomatous versus non-granulomatous vasculitis. So this is very simple. So they can ask which vasculitis are granulomatous or which are non-granulomatous, or which vasculitis are granulomatous vasculitis. Typically, you can remember both the large vessel vasculitis, that is your giant cell arthritis, and the Takayasu's arthritis. And out of the two small vessel vasculitis, the ones which have granulomatous in its name. So granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis, or EGPA. So these four vasculitis mainly are granulomatous. All other vasculitis are non-granulomatous vasculitis. So these four are your granulomatous vasculitis. Now coming to large vessel vasculitis. So remember, large vessel vasculitis, there are certain pointer words which help us in decoding this. Limb claudication or jaw claudication, difference in pulse or BP of the limbs, bruit, arterial bruit, renovascular hypertension, aortic dilatation, and large vessel aneurysms on CT angiography. So remember, if these 6 words are there, or if you can decode out of the question these 6 things, these are the typical pointer words for a large vessel vasculitis. Coming to medium vessel vasculitis, some of the pointer words for medium vessel vasculitis are, these patients typically will present with digital gangrene, abdominal pain, skin, nodules or a non-healing ulcer. Again, they can present with renovascular hypertension, mononeuritis multiplex, and again aneurysms. So typically abdominal pain, remember for the question and for the clinical presentation, abdominal pain is a very important pointer out because these patients are prone for mesenteric artery thrombosis and mesenteric ischemia. So these are the pointer words for medium vessel vasculitis. So these are the words or these are the clinical clues which will help us in guiding for diagnosis. Small vessel vasculitis. The pointer words or the pointer clinical features are palpable purpura, urticaria, lung. Usually lung will show alveolar hemorrhage due to pulmonary capillaritis. Remember renal system, there is rapidly proliferative glomerulonephritis. As a feature, these typically have ENT manifestations, and out of these, typically your older name, Wegener's, the newer name GPA, has mainly ENT manifestations. And there are eye manifestations like uveitis, scleritis, and episcleritis. Once we decode the entire vasculitis too, all this will fall into picture. But just for now, remember these pointer words or pointer clinical features for each type of vasculitis. So now coming to large vessel vasculitis proper. Okay, so mainly large vessel vasculitis typically involves the large arteries. That is your carotid arteries mainly. And its major branches. Okay, so this we are dealing with a clinical entity that is giant cell arteritis, which is a large vessel vasculitis, where the carotid arteries and its branches are mainly involved. So as you can see in the diagram, the carotid artery and its branches are involved. Vis-a-vis, this is your Takayasu's arthritis. Where the arteries which are involved are your aorta and its major branches. Now coming to giant cell arteritis. So every vasculitis, you should know something known as the ACR criteria. That is the American College of Rheumatology criteria. And according to that, if some clinical features are present according to the laid down criteria, we can diagnose the patient as having a particular type of vasculitis. So this for giant cell arteritis, typically the patient has these features and 3 out of 5 of these features should be present. So the age of the patient at onset of the disease should be more than 50 years. Patient should present with a new onset headache. There should be tenderness or decreased pulsation in the region of the temporal artery. So as you can see over here, there is tenderness in this temporal artery region in this diagram. The ESR should be more than 50 and there should be a positive biopsy, positive temporal artery biopsy. So to make it easy, you can remember there are 2 50s over here. What are those 50s? The age and the ESR, both should be more than 50. And apart from that, you can remember headache. And again, 2 things related to your temporal artery. Tenderness or decreased pulsation of the temporal artery and a positive temporal artery biopsy for vasculitis. So if you remember in these terms, two rules of 50, age and ESR, and 2 points related to your temporal artery and headache. So out of these 5 things, if 3 are present, we can diagnose the patient as having giant cell arteritis. So typically, patients usually present with these features. They usually present with a unilateral abrupt headache, usually one-sided headache. So in the older people, especially patients who are more than 50 years of age, never ignore unilateral headache and don't just label every headache as migraine, unilateral headache. This is very important. These patients can present with a unilateral abrupt headache, or they can say something known as scalp pain, wherein they have difficulty in combing hair. They can complain of tongue or jaw claudication. Visual symptoms, that is, there is transient blurring of vision, or known as amaurosis fugax, or they can present with diplopia, or constitutional features like fever, weight loss, and anorexia. So these are the typical clinical features of giant cell arteritis. And I told you the ACR criteria also. 3 out of 5 features. We already discussed that. On examination, the temporal artery is thickened usually, and it is tender on palpation. And very, very, very important thing is this thing. These patients usually have an afferent pupillary defect. Okay, so in the question, especially for MRCP exams and for internal medicine residents who are going to write the NEET SS, this is very important. These patients have something known as afferent pupillary defect. And more about it, we'll discuss in our classes on CNS, what is afferent pupillary defect and other pupillary defects. But just remember for now, afferent pupillary defect is there. And 10% of these patients usually can have something known as anterior ischemic optic neuropathy. And this can lead to permanent blindness. So that is why if you suspect a patient is having giant cell arteritis, you have to start treatment for this patient, because they usually can have bilateral AIOI later and can have blindness of both the eyes. So that is why treatment should be initiated at the earliest for these patients. And gold standard is obviously temporal artery biopsy. But remember, very, very important catch over here. This disease is prone for skip lesions. What does that mean? Suppose this is a temporal artery. So this part might get involved. This part might get involved. So there is patchy involvement. These are known as your skip lesions. So remember, if you are taking biopsy of the patient, and unfortunately the biopsy sample has this part, which is normal. So you might get confused that this patient might not have a giant cell arteritis because the temporal artery biopsy sample is normal. But always remember, this disease is prone for skip lesions, and that is why you should pick 3 out of 5 of those ACR criteria, and not just this criteria for diagnosis. No doubt this is the gold standard investigation, but always remember about this part about skip lesions. Now coming to Takayasu's arthritis, remember about these 2 large cell vasculitis which we are going to deal with. So giant cell arteritis typically is a disease of the old, or typically patients are more than 50 years old. Whereas Takayasu's usually involves around 3rd to 4th decade patients. Okay. So coming to Takayasu's ACR criteria, for this we can remember it by the mnemonic A, B, C, D. So for Takayasu's arteritis, so how do you diagnose it? So 3 features should be present out of 6. That is the ACR criteria for Takayasu's arthritis. So A stands for age at the disease is usually less than 40 years, which I told you. And along with that, angiographic abnormalities are present. So there are two A's and there are two D's, and there is B and C. B is presence of arterial brouillon auscultation. C is again features of claudication. Claudication of limbs typically these patients have, whereas in giant cell arthritis, I told you about jaw and tongue claudication. And D is decreased pulse and BP of the limbs. So out of these 6 features, so this is one feature, this is second feature, third feature, fourth feature, fifth feature, and sixth feature. So out of these 6, if 3 are present, we can diagnose the patient as having Takayasu's arthritis. Okay, so coming to the clinical presentation. So these patients, as discussed, the age is typically less than 40 years. These patients can have a giant cell arthritis-like presentation because, as I told, the aorta and its branches are typically involved, and hence carotid arteries can also get involved, and the patients can have presentation like giant cell arthritis. These patients can present with young stroke or MI. That is whenever a patient, especially a patient who presents with stroke in the young or younger age groups, we always make it a dictum that in young stroke, check BP in all the 4 months and pulses as well. This is typically asked a question in the vivas, causes of young onset stroke. So remember, Takayasu's arthritis is an important cause. Myocarditis, which is there here, is reversible. Okay. And these patients, as discussed, can present with renovascular hypertension. So the myocarditis is typically reversible. Now the gold standard investigation here is CT conventional angiography. Vis-a-vis, as we had discussed in giant cell arthritis, the gold standard investigation was temporal artery biopsy. So typically, the upper limb pulses are usually absent because the aorta and its branches typically supplying to upper limbs are mainly affected. And these patients can present with renovascular hypertension. And most common vessel involved is the subclavian artery. So all these are important points to remember for Takayasu's arthritis. Now both these conditions, how is the treatment started? So mainstay of treatment is typically corticosteroids. And as we've discussed, if there is a suspicion of giant cell arthritis like presentation in both giant cell arthritis and in Takayasu's arthritis, you have to start steroids early. Because these patients, as we have discussed, giant cell arthritis are prone for ARN, and that is why they can have blindness. So corticosteroids is the mainstay of treatment. That is why these corticosteroids should be initiated early.